So the reason of conflicting results about ovarian reserve is mainly because of the difference of the following variables: patient management, stimulation protocols, laboratory procedures, other factors interesting to each institution, selection criteria, and control group. When we check literature, we can see that there are three main control groups: two-factor infertility, endometriosis without endometrioma, contralateral normal site in patients with unilateral endometrioma. In this study by Gerard et al. 2002, they compared ovarian response in patients under 35 years old with previous ovarian surgery and control group in ART sites. They found that number of oocytes was significantly lower in previous ovarian surgery, and other parameters did not show any significant difference between groups. But when they compared ovarian response in patients over 35 years old, and they found that number of follicles, number of oocytes, and pregnancy rate significantly lower in the previous ovarian surgery group, and number of ampoules required for stimulation was significantly higher in the ovarian surgery group. Another study by Garcia-Velasquez et al. In 2004, in this study, patients with endometrioma about 3 cm were included in the study, and they compared ovarian removed patients with and ovarian present patients. They found that total FSH dose was significantly higher in the endometrioma removed patients, and peak E2 levels was found significantly lower in the endometrioma removed patients. But they found complications, and cystectomy in symptomatic cases has no deleterious effect. Other study by Esinler et al. From Turkey, 2006, a patient with endometrioma about 3 cm were included, and they are being compared. Three groups are being compared: unilateral cystectomy, bilateral cystectomy, and control group. You see the inclusion and exclusion criteria. And number of oocyte complex was found significantly lower in the bilateral cystectomy group than the other groups, but number of embryo transfer and clinical pregnancy rate did not show any significance between three groups. And in the same study, when they compared operated versus non-contralateral ovary in patients with unilateral endometrioma, number of oocytes was found significantly lower in the operated ovary group. As a summary of this study, endometrioma cystectomy does reduce the ovarian reserve. However, number of embryos transferred and pregnancy rate comparable among the three groups. And first prospective randomized study from Demirel et al. 2006, they compared ICSI after surgery group and ICSI directly group. And ovarian surgery resulted in longer stimulation, higher FSH department, lower oocyte number, but pregnancy rate and fertilization rate did not show any significant difference between groups again. In this review by Sumbiana et al., you see the studies comparing operative endometrioma and tubal infertility. In the studies of Geber et al. And Papucci et al., you see the number of oocytes retrieved was found significantly lower in the operative group, and the other studies did not show any significant difference between groups. And you see the studies comparing affected ovary and intact ovary in patients with unilateral endometriomas. In these three studies, you see number of oocytes significantly lower in the control group, but other three studies did not show any significant difference. And another study by Sumbiana et al. 2008 about bilateral endometrioma, they compared previous bilateral endometrioma cystectomy group and no surgery group, And they found that number of follicles, oocytes through embryos obtained were significantly lower. And pregnancy rate is also lower than the control or no surgery group. And they conclude that IVF outcome is significantly impaired in women operated for bilateral endometrioma. When we look at the ovarian damage mechanism, we can evaluate this in two groups: endometrioma-mediated damage and surgery-mediated damage. An explanation for endometrioma-mediated damage are Manish et al. Found that reduced number of follicles and sudden surgery in cortex surrounding endometrioma, and Kaplan et al. Found endometrial implants in the ovary decreased the number of ovulation points in the rabbit model. And the explanation for surgery-mediated damage are inadvertent removal of primordial follicles, inflammation, and heterosurgical coagulation. In this studies about inadvertent removal of primordial follicles during cystectomy, in this studies of Musi et al., they found that presence of primordial follicle in 54% of endometrial cyst wall versus in 6% of non-endometrial cyst wall. Sugar et al. Found that presence of primordial follicle in 69% of the endometrial cyst wall. And other factors for surgery-mediated damage are local inflammation, heterosurgical coagulation, and adverse changes in ovarian artery blood flow after surgery. For prevention of the damage, bipolar coagulation should be performed with caution. Laparoscopic ovarian suture may be a less detrimental hemostatic procedure. And what should endometrioma be exist before IVF cycles? 3 variables should be considered: bilaterality, dimension of cyst, and number of previous ovarian interventions. The major problem of the studies are selection criteria, such as size of endometriomas, presence of adhesion, pain symptoms, age, duration and cause infertility, and etc. So most of the studies show us surgery does not benefit symptomatic women preparing to undergo IVF are found to have an endometrioma. And supporting tools of expected management are surgical-related damage, minor and major surgical complication, economic cost, and lack of evidence that surgery improves IVF pregnancy. And supporting tools of surgery are risk of pelvic abscess, ruptured endometrioma, risk of cult malignancy, retrieval difficulties, contamination with endometrioma content, and endometriosis progression. And the other topics is relationship between endometriosis and endometrial receptivity. When we review the literature, we can see that embryo recipients with endometriosis have the same implantation and pregnancy rates as recipients without endometriosis. So, endometrial receptivity is not compromised in women with endometriosis. In this slide, you see a roadmap by Garcia Velasco and Soloviana. If a patient has no previous intervention for endometriosis, and if ovarian reserve is intact, if pain symptoms is present, if there is monoarterial disease, and if sonographic feature of malignancy is present, and if there is rapid growth of cyst, so surgery is being recommended. Otherwise, expectant management recommended. And in this slide, you see the international guidelines about this issue. And according to the European Society, surgery is recommended if endometrioma above 4 cm. According to the American Society, surgery has doubtful benefit and they don't recommend. And Royal College, according to Royal College, again, surgery is recommended if endometrioma above 4 cm. And my conclusions are, the presence of endometrioma may negatively influence ovarian function. There are difficulties and risks during retrieval. So we should do meticulous endoscopic surgery in symptomatic cases, and surgery does not benefit ART in asymptomatic cases. The magnitude of the negative effect an ovarian result is unknown, and laparoscopic ovarian cystectomy is recommended if an ovarian endometrioma of 4 cm according to ASH and Royal College guidelines, but there is no strong evidence for this. And results from large randomized controlled trials are needed to state whether or not ovarian endometriosis should be treated before IVF. And the most importantly, personalized approach is essential. The age of woman, the presence and absence of pain, the number of previous interventions, ovarian disorder, the possibility of acute malignancy are very important factors to make a decision. Clinician and patient should be aware that the expected benefit is operator dependent. Thank you for your attention.